We're going to systematically lock down the primary survey, objective measurements of burn depth and body surface area, the fluid resuscitation protocol, wound management, and finally, we'll hit those high-stakes special burn mechanisms.
Section 1. The primary survey.
Now, never forget this. A burn patient is a trauma patient first. Looking at the official ATLS-based algorithm, you'll see a very specific flow. Airway and initial fluid checks absolutely have to happen before you even think about wound care. Seriously, don't get distracted by the burn itself until your trauma fundamentals are totally secured.
Our primary survey priorities follow the classic ABCs. Step 1, airway. You want a super low threshold for early intubation here. Step 2 is breathing. Hit them with 100% oxygen right away. Step 3, circulation, meaning aggressive fluid resuscitation. And step 4 is exposure. You've got to stop the burning process literally immediately. Get all their clothing off, especially any melted synthetics, and take off all jewelry before the tissue swells up and acts like a tourniquet. You also need to watch like a hawk for specific triggers of airway compromise. If they were in a closed space, you've got to suspect inhalation injury. Be on the lookout for hoarseness, stridor, and singed facial hair. But your absolute classic exam trigger, carbonaceous sputum. If you see that, or any carbon in the back of the throat, you have to act fast. Supraglottic edema progresses incredibly quickly over the first 12 hours. Because of that, early awake intubation is always your best bet. Way better than trying an emergency cricothyroidotomy on a massively swollen neck.
Section 2. Burn depth and body surface area, or BSA. Objective measurement is absolutely crucial because it dictates all the math we'll do later. The 3 clinically important depths we care about are superficial partial thickness, deep partial thickness, and full thickness. Superficial partial thickness burns hit the papillary dermis, and as you'd guess, they are incredibly painful. But look at deep partial and full thickness burns. These go deep into the reticular dermis, fat, fascia, or even bone. The key takeaway here is that they are classically painless and insensate. Why? Because the heat literally destroyed the nerve endings. Moving on, we calculate the extent of the injury using the rule of nines. But you've got to notice the visual differences between adults and kids here. Infants have a proportionally much larger head, up to 18% of their BSA, and smaller lower legs compared to adults. You absolutely have to adjust your math based on the patient's age. If you need a fast rule of thumb to speed up your clinical calculations, use this. For scattered, patchy burns, use the patient's hand, and that includes the palm and the extended fingers, to estimate about 1% BSA. But for large, contiguous burns, you're going to rely on the rule of nines.
Section 3. Fluid resuscitation protocol.
You know, improved survival in modern burn care is largely thanks to aggressive, highly calculated volume replacement. You need to have the consensus formula down cold. The lactated Ringer's volume for the first 24 hours is 2 to 4 milliliters multiplied by the percentage of BSA burned multiplied by the patient's body weight in kilos. You give exactly 1/2 of that entire volume in the first 8 hours and the rest over the next 16 hours. And here's the massive kicker. That clock starts at the time of the injury, not when they finally roll through the ED doors.
Let's lock in some major exam traps regarding this Floyd math, because they love to test this. First, only count 2nd, 3rd, and 4th degree burns. Epidermal 1st degree burns, they do not count toward your BSA calculation. Second, always remember to subtract any pre-hospital IV fluids from your total. Third, for kids weighing 30 kilos or less, you have to add a D5 1/4 normal saline maintenance fluid to make up for their huge evaporative losses. And finally, the ultimate trap, strictly avoid colloid solutions like albumin in the first 12 to 24 hours. Giving them during that initial capillary leak phase will actually increase the relative risk of death.
So how do we actually know if our fluid resuscitation is working? Urine output. A Foley catheter is completely mandatory. For adults, your target is 0.5 mLs per kilo per hour. In pediatrics under 30 kilos, target 1.0 mLs per kilo per hour. Hitting these exact numbers is your single best index of adequate tissue perfusion.
Section 4. Wound care and management.
As we transition from acute stabilization to infection control, remember that topical antimicrobials are your go-to for local burn management. You need to drill their unique side effects into your brain. Silver sulfadiazine is painless, sure, but it causes transient leukopenia and doesn't penetrate eschar very well. Mefenide acetate, on the other hand, penetrates eschar beautifully, but it hurts like crazy and, here's a high-yield fact, it can cause metabolic acidosis because it inhibits carbonic anhydrase. Finally, silver nitrate is safe if they have a sulfa allergy, but it stains tissues completely black and causes severe electrolyte abnormalities.
Now, pay very close attention to this strict protocol rule. Systemic antibiotics are never given prophylactically. Just don't do it. They're reserved strictly for documented infections, defined by a tissue biopsy showing more than 10 to the 5th organisms per gram of tissue. Next up, the standard of care involves early tangential excision of the burn right down to bleeding capillaries. But you have to limit this to less than 20% BSA or 2 hours of operating time so you don't cause profound blood loss and hypothermia. Oh, and don't forget the tetanus shot. Give them a booster if their last one was more than 5 years ago.
You also have to be on the lookout for mechanical complications. Deep, circumferential, full-thickness burns can literally strangle a limb as tissue edema builds up, or they can completely restrict chest wall expansion. If circulation distal to the injury starts getting impaired, you need to do bedside longitudinal incisions, eschorotomies. They are absolutely life-saving.
Section 5. Special burn mechanisms.
Let's start with carbon monoxide poisoning. If a patient comes from a confined space fire, look for the classic cherry red lips and a headache. CO binds to hemoglobin with an affinity 249 times greater than oxygen. That's insane, right? So the math of the treatment is crucial. On regular room air, CO's half-life is 250 minutes. But if you blast them with 100% oxygen via a non-rebreather mask, you drastically accelerate that clearance, dropping the half-life all the way down to just 40 minutes. Also, always remember to check a baseline arterial carboxyhemoglobin. Next up, electrical burns. Alternating current, like what you find in household lines, causes tetanic contractions. This is that classic grip effect that traps the victim to the source, and it often leads to cardiopulmonary arrest. Direct current, on the other hand, like lightning, causes a single, massive contraction that usually throws the victim completely away from the source. The scary part? Electricity passes along the paths of least resistance, like nerves and blood vessels. That causes hidden, deep tissue necrosis that is totally out of proportion to the tiny entrance and exit wounds you might see on the surface. Which leads us straight into a massive exam distractor, the electrical burn trap. All that deep tissue destruction causes rhabdomyolysis, which dumps massive amounts of myoglobin into the blood, turns the urine dark, and threatens acute renal failure. You absolutely must override the standard Parkland formula targets here. You have to aggressively increase IV fluids to maintain a urine output greater than 2 mL per kilo per hour to flush out those kidneys. Finally, let's talk chemical burns. The golden rule here is immediate removal of the offending agent. If it's a dry chemical, brush it off before you apply water, or you're going to activate it. Then, irrigate the area with copious amounts of water for at least 20 to 30 minutes. Keep in mind, alkali burns actually penetrate much deeper than acid burns. And here's the ultimate trap. Aggressively resist the temptation to use neutralizing agents. Trying to neutralize an acid with a base, or vice versa, creates an exothermic reaction that will literally generate heat and make the thermal injury even worse. Okay, we have covered a tremendous amount of high-yield data today. So let's wrap this up with a final provocative thought to test your immediate recall. Imagine a patient from a house fire comes in with hoarseness, facial burns, and a blood pressure of 80/43. What is the very first step in management? Are you tempted to fix the hypotension with fluids? Well, don't be. Securing the airway early always beats rushing to fluids. Intubation is your answer here. Remember, burn patients are trauma patients first. Keep that core structure in mind, and you are going to navigate any burn scenario effectively.